because we do not want to do revisions for these patients. So knee osteoarthritis, when you have a cartilage lesion, the solution is a la carte. So we should consider the age of the patient, gender, the weight of the patient. Is it a chronic or degenerative lesion? What is the location? What is the depth? How big is it? What is the patient is demanding? It is high demand or low demand patient? Is the knee stability stable? There is a malalignment or not? So many factors can affect our choice of treatment in cartilage lesions. Let me ask you a question. Like the previous cases, 54-year-old man, this man is a former volleyball professional player, but now he's 54. He's 2 meters and 2 centimeters high, 141 kilograms, and he is a businessman, high level. So he has pain and recurrent refusions since 5 years in his left knee and full range of motion. So at the examination, you can see pain at the patellofemoral joint and the medial compartment. The X-ray is that, and the malalignment is only 5 degrees, equal to the other knee, nearly. So what will be our choice? Just do an arthroscopic debridement that will fail in 6 months. We can consider a high tibial osteotomy with 2 meters high, or unicondylar, or total knee, or well, we will say the patient, as much of us do, you can survive till you survive, then we'll do a total knee to you. So this is her knee, his knee, and we performed this surgery like 2008 or 9. This is a inlay resurfacing of the knee. This is a very minimal invasive surgery. There is no bone loss. And the patient is, after 1.5 years, was playing veteran volleyball. And this is the 13th year of X-ray. He still doesn't require, in means of complaint, total knee replacement. And the narrowing of the joint has not been changed too much in 13 years still. And now is like 67 and deserves a total knee. So, indications for total knee arthroplasty is pain, deformity, loss of range of motion, and function. So if you have 2 of these 5 symptoms, and the patient is over 65, let's say, you can apply a total knee to the patient. But there is a huge gap between the patient that we do biologic reconstructions, like from microfracture to mosaicplasty or autolog contrasite transplantation or allograft transplantation, between the ages of 35 and 60. And there are also patients that we did biologic reconstructions and failed. Or in our hands, due to our experience, we think that biologic reconstructions will fail. So the arthrosurface technique, inlay resurfacing, are suiting in this gap. Patients who are young for TKA, but unsuitable for biological methods. So you can find lots of publish about this method and also algorithms, but traditional unicondylar is not a pre-treatment before total knee. If you do a uni, it will be for life. It's like total knee. I mean, you will not consider it to change the total knee after that. You will do it for 25 years at least, in my opinion. And that's a bone loss of a uni. And this is a bone loss of a arthrosurface. So let me show you some indications. Of course, patient selection is very important. It should be a high demand patient and he should be a localized lesion. So 50 years old male, white collar, pain and repetitive effusions of the knee for 3 years. She had physiotherapy, some injections on anti-inflammatory agents. And this is his knee. So very good alignment. I always check the alignment. I'm also osteotomy guy. And this is his main problem. No maltracking. If there is a patellofemoral maltracking, I could consider a tibial tubercle osteotomy, anteriorization, or if needed, medialization, changing the surfaces. So this is the coverage and this X-ray. Another example, 56 years old male, free profession. Again, he's a good tennis player, high demand patient. He has a pain at the medial joint space. So we did a big inlay resurfacing to his knee with patellofemoral UC. And this guy is post-op 3 months, can do everything with Cybex even. Another example, 58 male accountant. He is doing fitness and cardio regularly, pain at the patellofemoral joint. So there is no incongruence in the patellofemoral joint. It's very important. You see the isolated, and you know the microfracture technique is unsuccessful, most unsuccessful in the patellofemoral joint, as we all know. So we did only he has a localized lesion in the patellofemoral trochlea. This is him. It's post-op 12th day. You see still he has the dressings in his knee, and it's a very small incision with mini arthrotomy. That's a good solution for him. So I've done like near 40 cases HDO combined resurfacing. So I had the chance to see what is happening to these implants while extracting the HDO implant, like at least 1 year later. So I saw that even you cover a defect in the body, in the cartilage defect, cover something, the body is covering it, even if it is a metal with some cartilage, maybe a fibrocartilage, doesn't matter. So the main philosophy in the management of cartilage lesions, if you have a cartilage lesion, it will not heal. It will get bigger in time, of course, depending to your weight, activity level, and having a knee trauma or not. But the cartilage lesion will go forward, beginning from the medial, let's say, to the trochlea, then to the lateral, and this is the common story. It will take 5 years, maybe 25 years. But if you have an acute cartilage lesion, and somehow, with biologic or non-biologically, you resurface it, it will prevent the progression of the osteoarthritis, or may prolong the time to go to total knee replacement. So we have published the coverage of the cartilage into the implants in the cartilage journal. This is not an alternative for a total knee. This is an alternative for focal cartilage lesions, resurfacing, that we cannot perform biologic reconstruction for long term. So limited inlay resurfacing arthroplasty in very good selective cases, who are active, biologically young, or active or biologically young, high demanding, knee osteoarthritis in 1 or maybe 2 compartments like medial and trochlea or lateral and trochlea, an option before TKA, single or combined with other surgeries. If there is malalignment, you have to correct it with this surgery too. For eliminating these symptoms, it's a successful method. So disadvantages, I have now like 13 years, my oldest patient is 14 years ago I did this. About 152 patients I have. Some of them are combined with osteotomies. I have revised with total knees, regular primary total knees in 5 patients. All of them were in their first surgery were over 60. So these patients were revised. At the shortest was at the 8th year, and the last one was at the 12th year. So their ages were over 70 now, and they had total knees. Other than all the implants are surviving. Thank you very much for your patience.